G'day, I'd like to let you know that AussieMedEd is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. Good day and welcome to the AussieMedEd, the Australian Medical Education Podcast, where we get to interview specialists in a variety of medical areas, asking their opinion on their certain conditions and obtaining their insight into how they diagnose and treat that condition. In these COVID times, it's a way of replacing the relaxed discussion around the hospital by allowing the listener to put forward questions to be answered and addressed on their behalf. I hope you enjoy the whole program and welcome once again to AussieMedEd. In this episode of AussieMedEd, we get to interview Dr. Nick Knight, an anaesthetist who's going to give his opinion and advice regarding airway maintenance, intubation versus laryngeal mask, stages of anaesthesia, complications of anaesthesia to be aware of, and medications often used during anaesthesia. I'm Gavin Nyman, an orthopaedic surgeon based in Adelaide in South Australia, and I'm the host of this podcast. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced, and pay my respects to the elders both past and present. It's my pleasure now to introduce Dr. Nick Knight. He's an anaesthetist who works at Pulse Anaesthetics as well as a staff specialist at the Royal Adelaide Hospital in South Australia. He completed medical school at the University of Oxford and studied at the Royal Free and at the University College of Medical School in the United Kingdom. He now works in Adelaide in South Australia, and I'm very pleased to have him on this program to talk about different aspects of anaesthesia. Dr. Nick Knight. Nick, it's great to have you on board. Thanks very much for joining us with AussieMedEd. It's really great to have an anaesthetist here to answer a few questions from the medical students. One of the first few questions I've asked us about is actually about preoperative assessment. What do you take on board when you go to assess a patient prior to an anaesthesia?
Well, like anything in medicine, it's done by history, examination, and investigation. Probably more so on the history. First thing we always ask is about previous anaesthetics and have there been any problems? And the answer is no, usually no, but it's nice to know if they have had any specific issues before. Other things that are important to know are about other medical problems that the patient may have. So we take a full medical history, particularly with the cardiovascular and respiratory system, although any system is important. We like to know about what medications they're on. If there's any potential for interactions with the anesthesia or that might pose problems for the surgery. And we like to know if they have any allergies that may or may not be specific to anesthesia. We also, for our examination, we do look at all systems, again, particularly the cardiovascular and respiratory system, but we do an assessment of the airway as well to see whether, one, if there'd be an easy airway to manage, and how easy they might be to put a tube into. Moving on to investigations, which if they're fit and healthy, doesn't have to be done, but common things would be blood tests, and then if they have any respiratory or cardiovascular issues, we might look to things like chest x-rays, pulmonary function tests, or echocardiograms, ECGs, those kind of things.
What about fasting? How important is the fasting time for an anaesthesia?
Yeah, fasting is important. So generally, we like patients to be fasted for 6 hours for food, 4 hours for non-clear fluids, and 2 hours for clear fluids. So that's things like water. And the reason for this is we don't want patients to aspirate. So if they have an empty stomach, the risk of aspiration is vastly reduced. We don't generally anaesthetize patients who have a full stomach unless it's an emergency situation because there is a significant risk of aspiration.
That's a good question for a medical student. So saying there's an emergency scenario, is there a way of giving an anaesthesia safely in that situation?
Yes, there is. So again, if it cannot wait until the patient's fasted, we would proceed with anaesthesia. If we have to give them a general anaesthetic, we would provide anaesthesia or induction through a rapid sequence induction. Perhaps prior to that, we would give an antacid, so something like sodium citrate to neutralize any acid that is sitting in the stomach. That doesn't make any difference to any solid food that might be sitting there. and then we'd pre-oxygenate them and put on cricoid pressure and use drugs that will increase the speed at which anesthesia induction occurs so that we can get a tube in quickly and minimize the risk of aspiration.
So what does pre-oxygenation involve?
So pre-oxygenation, we do that really because the body's reserves of oxygen are very small. There's very minimal oxygen stored in the blood. Most of your oxygen is stored in your lungs, so in your functional residual capacity. So when we're breathing air, as you know, air is mostly nitrogen, 70% nitrogen, and only 21% oxygen. What we want to do is wash out all the nitrogen and replace that with oxygen so that your functional residual capacity then is full of oxygen, and that is then your reserve of oxygen while you're apneic, or while we try and get have the airway controlled. Until we have the airway controlled, we've got a reserve of oxygen there so that they don't desaturate and their oxygen they don't become hypoxic.
Obviously, in a standard general anaesthesia, it can be broken down into different phases, I believe. I believe it's induction, maintenance, and emergence. Are they the terms that you would use, and what are the different stages involved, and what medications would you use involving in those stages?
Medications are quite varied, and everyone uses slightly different things. But generally speaking, we would do inductions with an IV general anaesthetic, something such as propofol or thiopentone. Maintenance is, once the case is underway, we keep the patient asleep, and that can be done with IV anaesthetic agents, again, such as propofol. But an alternative that a lot of people use are volatile anaesthetics, and that's by inhalation, and that keeps the patient under anaesthesia. And then emergence is when the patient, the surgery is finished, and you want them to wake up at the end of it. And again, depending on what drugs you've used, you need those to come down, so the concentrations in the plasma to come down, and therefore concentrations in the brain to come down, so that the patient will then wake up. So for induction, we generally use an opiate, because having an endotracheal tube put through your vocal cords is very stimulating. Some propofol to actually anesthetize the patient, and muscle relaxant to aid with intubation to relax the vocal cords. And then maintenance, you can either use IV propofol or continue with a volatile anesthetic such as sevoflurane or desflurane, which is an inhalational anesthetic. And then at emergence, you would wait for the effects of those to wear off and their plasma concentration to reduce. So if you're using a volatile anesthetic, that's the offset. You offset that by breathing the volatile anesthetic out. And then muscle relaxation is used at the beginning of anesthesia at induction to aid with intubation, laryngoscopy intubation, to relax the vocal cords. It may be required during surgery to relax muscles, depending what the surgery is. For instance, abdominal surgery, laparotomies, you will need the patient relaxed. Sometimes, depending where the actual surgery is occurring, you don't necessarily need muscle relaxation. If you have used it for emergence, you either need to wait for the effects of that to have worn off, or to help those effects to help wear it off, or to antagonize it, you can give a reversal agent as well to aid with that.
Excellent. And with anesthesia is done with a inhalation, so people might be scared of needles, and therefore the person's put off to sleep with some gas. What's done in that scenario? Is that
the volatile anesthetics can be used for induction of anesthesia. We'd call that a volatile induction, and with that it's commonly used in children, because it's a bit more pleasant than having a needle stuck in your arm. So with that, we get them to breathe through the mask on a closed circuit, usually sevoflurane, and perhaps adding in some nitrous oxide, which is also another anesthetic agent. They will breathe on that, and that will get them anesthetized. And then once they're anesthetized, we can put an IV cannula in place and give any drugs IV that we need to.
And what about the differences nowadays between laryngeal mask and intubation itself? I'd like to let you know that Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au. Years ago, it used to be purely intubation. Now I believe laryngeal masks have come on the scene and are quite popular.
Yeah, so laryngeal masks were invented probably about 30 years ago. They're a supraglottic device in that they sit above the vocal cords, above the glottis, and they're not a secure airway in the same way that an endotracheal tube is. So an endotracheal tube is a tube that will go through the vocal cords. In modern anaesthesia, we usually use a cuff, so that sits below the vocal cords, and that seals the airway so that we can do positive pressure ventilation, and it will prevent any aspiration or of any regurgitated stomach contents. A supraglottic device doesn't have quite the same seal. It sits above the vocal cords. While you can give positive pressure ventilation through this, most of the time we'd use it with spontaneous ventilation. So it provides a patent airway, but it's not a secure airway, and it doesn't protect from aspiration of regurgitated contents. However, the depth of anesthesia doesn't have to be as deep because it's nowhere near as stimulating as having an endotracheal tube put through your vocal cords.
So that means they can have a lighter anaesthetic and they're not so nauseous when they wake up, I believe. Is that correct? Or
possibly. I mean, you can perhaps run them a little bit lighter. You don't need as much opiates at the beginning to stick it in, and patients tolerate it very easily. Whereas if you have a patient with an endotracheal tube in place, it's very irritating, very stimulating, and they'll want it taken out if they're too light.
I'm always impressed by the number of monitoring you have on the anaesthetic machines. There's so many different numbers appearing there, monitoring oxygen levels. There's so many different controls. What are the main things you're looking at on those monitoring devices?
So the main thing is looking at monitoring the cardiovascular system. So that would be through ECG, pulse rate, and blood pressure. The respiratory system, by measuring oxygen saturation, but also looking at gas analysis. So we can look at end-tidal carbon dioxide, which gives us an idea of the arterial carbon dioxide partial pressure. But as well as that, we can look at oxygen levels in the gases that we're breathing in and out, and also the volatile anesthetic agents. We can measure, again, what they're breathing in and what they're breathing out. And what they're breathing out, once they've reached a steady state, gives us an approximation of the arterial concentration and therefore approximation of the brain concentration. They're the main things. Sorry, and also with the respiratory system, we look at airway pressures and flow volume loops and those kind of things to assess how well we're ventilating the patient.
Sometimes you need to put an arterial line in as well. Is that because you want to get a slightly better level of oxygenation, or is that for other reasons as well?
So the benefits of an arterial line are it gives you beat-to-beat blood pressure readings rather than when you do a non-invasive blood pressure reading, it's a cuff on the arm and you inflate that every 3 to 5 minutes, depending on what you want to do. And that just gives you a snapshot of what the blood pressure is at that point. The arterial line gives you a blood pressure reading on a beat-to-beat basis, and also tell you the pulse rate, and it can also give you an idea of whether the patient's adequately filled with fluid. We can look at the variation in the blood pressure on the arterial line. Plus, it gives us access to arterial blood, which we can use for sampling to look at oxygenation and other gas levels and do a blood gas from.
What about the airway maintenance? If you're during the process, how do you check if something plays up on the laryngeal mask or the intubation? Is there anything you're watching for?
So, I guess with the laryngeal mask, there's a couple of things we can watch. You've got the circuits, and if they're breathing spontaneously, you can look at the bag, which is just a reservoir bag on the end, and that will inflate and deflate as the patient breathes in and out, in inspiration and expiration. You can look at airway pressures, which is so as they breathe in, they'll have a negative pressure, and as they breathe out, they'll have a slightly positive pressure. If you then go on to positive pressure ventilation, the airway pressures are probably more important. You can look at peak pressures, and you can look to see whether there's whether it's particularly high pressures, which might suggest that you haven't got a patent airway for whatever reason with a laryngeal mask, or you can look for a leak. So if you're on low flows and you're not getting enough new gas going into the circuit, the bellows from the ventilator will start to drop, and you'll have to either turn the flows up or stop the leak. Ideally, stop the leak. If you've got an endotracheal tube in place, which again is a definitive airway, you can look at the airway pressures, and normally they'll go up during inspiration and then they'll come back down again in expiration. If they're particularly high, again, you need to look for a problem as to why that might be.
So therefore, there's a number of ways of keeping an idea of how well the patient remains intubated or how well the laryngeal mask is inflated. Really, the other thing is, what about complications of anaesthesia? Are there anything important the medical student needs to be aware of? I've learned about malignant hypopyrexia, which I believe relates to a lot to family history or previous, knowing that patients have previous anaesthesia is a good sign. Any other factors about that, and what is the importance of malignant hypopyrexia, i.e. how common is it?
So malignant hypopyrexia is a serious complication of anaesthesia. It's pretty rare though. It's a pharmacogenetic disorder of calcium homeostasis of skeletal muscle. So it is inherited, and these days it's quite common that you'll get some sort of history. You should be able to pick it up in the history, either from a family member having had a problem or the patient themselves having had a problem. But generally, if a patient's had a test, the rest of the family will get tested to see if they have it as well. It's triggered by certain anaesthetic agents, suxamethonium, which is a muscle relaxant, which isn't as commonly used as it used to be, and volatile anaesthetics. So any of those can trigger it, and it can come on quite quickly, but it can also have a very slow onset, and I've heard it can even come on a day or two after anaesthesia. However, it would usually come on over a period of about 30 to 60 minutes, and what we would see with that is a hypermetabolic state, and you would see high temperatures, high CO2 production, acidosis, and you may get it's a disorder of muscle, so you may get mastospasm, which is where the muscle at the jaw can go spastic, and if left untreated, muscle starts to break down, and the patient gets a metabolic acidosis and gets very sick, and it is life-threatening. Sorry, it is very rare, and it can be treated. So the main thing is to remove the trigger. So move to a volatile-free anesthesia, so that would be a propofol infusion. This is if it occurs, and the treatment is dantrolene, which is a drug that will reverse the effects of the MH, and the patient will need to remain intubated and go to ICU. They may need to be actively cooled, and all supportive measures until the dantrolene has its effect and the process is turned off.
So it's treatable, but it's also preventable if you're aware of it.
So if you're aware of it, or if the patient is at risk of it, either they've had it before, or they're confirmed case, or there's a suspicion, you would give an MH-free anesthesia. So you just don't give volatile anesthetics, and you don't use suxamethonium. All other drugs are safe.
Other questions the medical students have put towards you about actually the process of intubation. They're obviously wary of how they learn this. It's one of those processes they're always are keen to learn, but it's obviously quite a good technical exercise. What are the different steps you take in the process of putting a laryngeal mask in or intubation? What are the actual step-by-step processes you do?
Okay, well, look, we'll talk about intubation. So first, you do it as safe as you possibly can, and you plan all your steps beforehand. So you always have an anaesthetic nurse assisting you. You have all your equipment ready, and you have all your drugs ready, and then it's something that we're familiar with, and we do over and over again, and we would use the same steps each time. So it would start off by getting IV access in the patient, ideally, unless it's a child, but we'll assume it's an adult and we've got IV access. Initially, put all our monitoring on, and then we would pre-oxygenate the patient. As we said, the pre-oxygenating provides a reserve of oxygen in the body, in the lungs. So once they're adequately pre-oxygenated, which is generally either 3 large tidal volume breaths or a number of doing it for pre-oxygenating for a couple of minutes, or waiting till the expired oxygen is about 70%. Once that's happened, we would then give the drugs, which normally I would use a combination. So I would give some midazolam, some fentanyl, some propofol, followed by a muscle relaxant such as rocuronium. That, depending on what dose you give, that will take about 90 seconds to work. So at that point, you'll ventilate the patient with just a handheld bag, with a bag, a mask, and turn the valve so you can generate some pressure with the bag. So you're ventilating the patient, may or may not turn on some volatile anesthetic at this time to keep them asleep. And then once the muscle relaxant's had its effect, we'll get the laryngoscope out, which will be prepared at the side. The anaesthetic nurse will hand it to you, and you'll hopefully visualize the vocal cords, and then you'll take your endotracheal tube and pass that through the vocal cords, inflate the cuff, and then connect the patient back up to the circuit and confirm that the tube is in the right place. And to do that, you can look for fogging of the tube, which is the water vapor coming out of the lungs. You can feel the compliance of the lungs with the bag as you hand ventilate. But the definitive thing is looking for carbon dioxide on your gas analyzer. If it's in the esophagus, you won't get carbon dioxide. But if it's in the trachea, you will get carbon dioxide. The other thing you can do is auscultate both lungs to make sure that you haven't gone down the right main bronchus. And once you've done all that, you'll tie in the tube, and then you can pop them on the ventilator and give them volatile anesthesia, oxygen, some air, and proceed with surgery.
You've covered a lot of ground so far. I've got one more final question for you, and we really appreciate the excellent information. The final question is actually the reverse of all this. What about the process of extubation? What are the steps you do to prevent an aspiration or reduce the chance of that?
Again, it depends. In elective surgery, you would hope that the patient is we wouldn't have proceeded unless the patient was well fasted, so they should be relatively low aspiration risk. However, if it's emergency surgery and you're assuming a full stomach, they are still at risk of regurgitation and aspiration. So for extubation to occur safely, you need the drugs that you've given to have worn off so that the patient starts to wake up. You need them to be breathing spontaneously, and they need to be capable of maintaining their own airway. So we can aid that by turning off. If we're using volatile anesthesia, we turn off the volatile, turn up the flows, and the idea is they then breathe out the volatile anesthetic that's on board. And it's a slow process that will hang around for probably a few hours afterwards in very low levels, but they blow it off quite quickly. If they've got muscle relaxation on board, we either have to wait for that to wear off or give a drug that will aid in reversing that. So commonly we would use something like neostigmine combined with either atropine or glycopyrrolate. That increases the level of acetylcholine at the neuromuscular junction. Or if we've used a muscle relaxant such as rocuronium or vecuronium, we can use a drug called Sagamodex, which specifically targets those drugs and sort of mops them out of the circulation and therefore out of the neuromuscular junction and reverses their action. The patient will need to have a patent, capable of having a patent airway. So once breathing spontaneously on the tube, open their eyes and showing some signs that they're a bit more awake, we'll take the tube out. But I guess at all those times, and we'll also before we take the tube out, we'll suction their airway, and that's mainly to get rid of respiratory secretions, things like saliva that they can also aspirate on. But if we're very concerned that they're still with a full stomach, we can sit them up a little bit or turn them on their side, so that if anything does come out, it will fall out of their mouth onto the pillow, rather than going down into their lungs. But if we're very concerned, you could just keep the patient asleep and send them to the intensive care unit. But obviously, at some point, you're going to have to take the tube out.
Well, look, you've covered so much ground. I hope the medical students find this brilliant, and as I have today, it's been I've appreciated it a lot. And thanks again, Nick, for coming on the show.
Well, thank you, Gavin, for inviting me. Hopefully they can gain something from this.
The information provided to you today is designed to complement the information provided to you in your local region and should supplement your readings and teachings in that area. Please don't take it as the only way of treating this condition or assessing a condition, but really as one of various ways of assessing these conditions. Please also be aware that the information provided today is really just general medical advice and isn't designed to actually be a source of medical information regarding your particular condition. Remember to consult your specialist or medical practitioner if you have concerns about a condition raised in this podcast. Well, thank you very much for listening to our podcast, Australian Medical Education, or Aussie Med Ed. It's been a pleasure giving you this information, and I'd like any further feedback or questions directed towards me put towards gavin@med-ed.com.au. Any questions on a particular area of medicine will be directed towards a specialist in the area. We'll make it as a part of our podcast the next time. We look forward to hearing from you, and once again, we'll look forward to the next time you might listen. Thank you once again. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and TEGO, offering medical indemnity insurance for doctors. That's tego.com.au.